Hi, it's Roger Green. This week, all our posted conversations contain completed contents from our year-end interviews, edited only slightly for flow and background noise. Our final conversation of our 2022 wrap-up series is with our good friend Ian Rowe. This conversation looks at efforts in the UK to expand fatty liver screening into primary care, and we then go on to discuss the pivotal role NITs will play in patient management and the excitement around drugs coming to market. Just a reminder, Surfing the NASH Tsunami will have next day coverage of the 2 presentation days at NASH posting the Friday session around 6 p.m. Eastern U.S. Standard Time on Saturday, and the Saturday session around 6 p.m. Eastern Standard Time on Sunday. And here's Ian. So we wrap up our year-end interview series today with Ian Rowe from Leeds in the UK. I guess it's good afternoon there. How are you doing today?
Ian Rowe.
Yeah, very good, Roger. I'm just in the process of trying to wrap up all of the pieces at work before I go home and start wrapping up all of my presents.
It seems like there's a common theme for the day, hey?
Yeah, it's the same process, but subtly different, because wrapping up at work means finishing, but wrapping the presents is really just the beginning.
Yes, but hopefully if it's all wrapped up well, everybody gets joy when they open what you've done, right?
Yeah, well, I'm not sure which processes is going to give more joy. I suspect I know the answer.
That's funny. And then, of course, we have Jörn Schattenberg with us. Jörn, how are you this afternoon?
Jörn Schattenberg.
Hi, Roger. I'm fine. And I relate to Ian's comments. I'm kind of in the same position, so I had to smile. And I think I feel in a comparable seat.
I'm laughing because the interesting thing about Hanukkah, for example, is that it lasts for 8 nights. So you are wrapping up presents for a long time. It's a long wrap-up process. Let's just put it that way. And there's supposed to be small gifts every night. And you light candles every night. So every night you have insight. Every night you have wrap-ups. If you view candles as light as a source of insight. Different metaphors. Where I grew up in a neighborhood that was pretty evenly divided between Jewish people and Christian people at that point in time. The debate that the kids would have about, did you like Hanukkah, about did you like believing in Christ or should you not believe in Christ? And it came down to, should you get all your presents at once or should you get them over 8 nights? That's a very kind of 6-year-old view of the world. But this is a week in which, frankly, just shift focus at bad metaphors. This has been a week of gifts for fatty liver disease, hey? Starting as it did Monday with the release of the resmetirom MAESTRO-NASH 3 data and all the excitement that spread throughout the week. Ian, have you gotten to track much of that this week? And in conversations with colleagues, what are you hearing and what are people feeling about it?
So yes, I have been able to track a lot of it. It was very exciting, and in many ways I was away at a different trial steering committee meeting on Monday and was travelling back on Monday evening while you were recording the group conversation, and it's a real shame and disappointment to me to have missed that, because it really is a remarkable moment, I think, to see a drug meet both endpoints in a phase 3 trial in a way that I think is clinically meaningful for patients. And it's a milestone in the development of therapies in NASH, and I think it's one that we'll look back on, reflect on in the future as being something that really changes the way that we approach what we do. And that's been reflected in conversations that I've had here with colleagues about how we might need to think about our services to make them work better for patients who will need treatment and how we'll access that treatment. There's a lot of water to go under that bridge first, but being prepared now will make the most of the opportunity when it comes.
So could you elaborate on that a little bit? We've had lots of people talking about this with us, lots of different ways this week, but that's not a comment yet that's come up. So I'd love to just hear, I'm not even sure if that's what we're prepared to talk about, but I'd love to hear a little more about that.
We've currently got a service that looks after patients who've predominantly got advanced liver disease, whether that's F3 or cirrhosis. And patients who aren't in that more advanced group are largely being discharged back to primary care. So we need to think about how we organise our services locally so that we can access that population, if ultimately that is the population that's going to be appropriate for treatment, following the various reviews that will need to be in the UK, both regulatory and then from a cost effectiveness perspective with NICE. And then there are all of the other issues around interpretation of the results of the trial about the benefit to patients. All we've seen so far is the top-line results, and whilst those are very welcome, I think we recognise, and I've talked on the podcast previously about the difference between the regulatory endpoints, which is regression of fibrosis, and the real impact on patients, which may come through stabilisation of disease and particularly through prevention of progression. And it'll be really important to see those types of data as they're presented and ultimately when the manuscript's published, because I think that the clinical benefit is different to what the regulatory endpoints say. And whilst I don't think that this drug or perhaps any of the others will be completely effective against NASH, I think that the patient-facing benefit might be greater than what's already been reported. And I think it's important to bear that in mind.
So that makes sense to me. Jörn, what do you think?
It's an interesting aspect because what Ian is implementing or hinting at is that there's a lot more to that disease than the change range of categories on a fibrosis stage or NASH resolution under the microscope. And I'm full aligned with him here. It's very exciting to learn. We've seen some top-line results. There's a lot of it in it. I think the reason why I'm with you, Ian, and saying this, we're going to be looking back and saying this is going to really be a breakthrough, is we also have beneficial safety top-line data, what they revealed. And it seems that this could really move beyond what's been previously shown, because it's not the first trial to report a positive effect on fibrosis, but it's maybe the first one where we have both, and then also a more beneficial efficacy safety ratio. And the discussion is solely focused on getting the first drug across the finish line, which is the predefined FDA categories. But as you said, then all the other aspects come in: quality of life, changes in biomarkers. And I wonder how much we're going to be able to see, because it's, again, an ongoing trial. Can't risk deep blinding. It's a 5-year study looking at outcomes. And that will be quite a challenge moving forward. But it'll be interesting to learn how you implement that. And maybe we can also, I think as a field, we have to define how to implement that type of care. The next thing is maybe we can learn a little bit from the UK, because I think it's an obvious call that drug approval is going to be in the US, and Europe is sometimes perceived a little slower. For sure, we have more countries involved before a drug actually comes to market, and it might be that the UK is actually moving a little faster here this time. Maybe I'll learn from you, Ian, how you guys then use it once it'll become reality that we have a drug to prescribe.
I don't want to talk about any benefits of Brexit, because I don't really truly believe that there are any, but the but having a different drug regulatory framework might mean that approvals could come quicker, though I doubt that. And the process of approval through NICE, which is to show cost effectiveness, is likely to be iterative, because what's happened previously with high cost drugs is that the companies come with a cost effectiveness model, and then everybody goes into a dark room with all the windows blinded and the door closed. A different price is established to bring it into a cost effectiveness level, and then they come out again with an approval, and that's never a quick process. In contrast to what happened when the DAAs first came online, where there were early access programs. The case for early access programs, when you're not treating cirrhosis and patients are not at imminent risk of liver-related morbidity and mortality, I think is much harder to make. It's one that I expect that people will try to make, but I suspect in a UK, perhaps European perspective, that's going to be much more difficult. I don't know what you think about that, Jörn.
Yeah, I agree. I think there's going to be for sure more negotiation and talks required. And I mean, we're hypothesizing here on future outcomes. We'll have to see how the regulators view these results, and it'll be an interesting discussion in the first place. So while overly excited about the next steps, we of course got to take one at a time and see where it takes us.
Yes, agreeing with all that, and also agreeing, Ian, with your comment about early access programs. I think there's also something in the economics, which is that at the price per therapy or per patient of the DAAs and the immediacy of results, it was a lot more economically sensible to do whatever you had to do to get that drug into patients' hands immediately so you could start proving real-world experience. Here, somewhere between somewhat lower level of efficacy, I think I'd say 90 versus 30 or different levels of efficacy, and the fact that you could get results very quickly in measurable ways with DAAs in very sick patients, and here it's a little different. The public health case to be made for extensive early access probably isn't as strong either, and the motivation. So for all those reasons, I think that's accurate. On the other hand, NICE has kind of had a big month this month. As we've reported earlier in the month on the podcast, they seem to be at the end of making a decision to allow FibroScan to be used in primary care in the UK, which is a story we've been covering through the year because obviously it's of interest, I think, in general and specifically to Louise. But the first time we talked about this back in March, this was not a result that it looked like anybody was headed towards. How will that affect you and the practice of hepatology and the whole patient screening process in Leeds if, in fact, primary care has controlled but wider access to FibroScan?
So I think it's an interesting question. I think I've been on the podcast twice to talk about NICE and FibroScanning, and I was expecting my icebreaker to be what was my favourite moment of the podcast this year, and it was the second of the NICE discussions, which was held on Halloween, and Jörn came with a meat cleaver in his head to the podcast, and that's been the highlight of the recordings for this year for me. But in terms of access of primary care to testing, it's something that will be interesting to see how the uptake comes, and that will be around a case being made that testing is done better in primary care. And when I say better, I mean more efficiently and easier for patients. and that primary care are willing to take that workload on. So there is a recognition in primary care that liver disease is important and that they're seeing more of it and they're doing more testing. I'm involved in conversations with colleagues in primary care, not in Leeds, but across the UK, about how we might streamline or make testing for patients who've got risk factors for fatty liver easier, to take out some of the intermediary steps and allow those patients to have a fibrosis assessment more quickly. And that will definitely be made easier by having the availability of machines and trained staff in primary care to deliver those tests with appropriate decision support from specialists or from other providers. That will definitely help. The other thing that's happening in the UK is that there is a central research funder call out at the moment for studies in early diagnosis, and I expect that will involve it calls for fibrosis testing being made available in primary care. So I think there are several routes through which FibroScan will become, and potentially other tests will become more available in primary care over the course of the next couple of years. And it would certainly help us in secondary care, because that would be one less thing that we would have to do to optimise our referral pathways and to manage the flow of patients from primary care into our services.
Interesting stuff. A lot of progress on a lot of different fronts. So, Ian, two thoughts. Number one is, if we want to have a visual image of Jörn in 2022 to leave our listeners with, I'm going to run around to the Mazen Nuruddin side of the table, and I'm going to remind everybody that Mazen has nicknamed, and some of us have bought into the idea that Jörn's nickname should be Matt Damon. Thinking of Jörn visualized as Matt Damon might be a little bit more compelling than with the meat cleaver in his head.
I've never seen Jörn and Matt Damon in the same room at the same time, so we'd never know.
Now you got me.
So now we have the talented Professor Ripley, huh? So aside from meat cleaver, when you look back on 2022, what are the moments in either what you've learned or what you've seen, or both, that stand out most to you?
Well, so I think if you'd asked me that question last week, I would probably have said something about the increasing recognition that non-invasive tests are associated with prognosis and the pathways that will give us into the use of non-invasive tests for the stratification of patients for clinical follow-up and for treatment using a more risk-based approach. And I think that would have been what I would have said, I think. But obviously this last week's changed everything, because I think even the top-line reports of a phase 3 trial that reports improvements in both resolution of NASH and improvements in fibrosis, I think it's the standout event of the year. And we just have to see how that progresses during 2023, but it really opens up lots and lots of potential opportunities as time goes on. And I think that inevitably has to take precedence over the other findings. Whilst they're very important, I think the trial is the standout event.
So then, I think we all agree. Then I'm going to ask you to go back a week. So it's an interesting thing. You know, you came on last summer when we talked about what we thought were the big events of the year. I think that was this past summer. I don't know, it could have been 21, but I think it was 22. And you talked about ELF and the approval of ELF and the importance of that. I was noting recently that in the States, at least, LabCorp will now reflex you an ELF result if they run a FIB4 off data that's in an electronic medical record and identify FIB4 high. They'll just reflex ELF immediately if in fact the institution allows that, thereby taking one more efficient step towards the process, at least in the States, of identifying patients who are at significant risk quickly, which I think was the kind of thing you were talking about then, actually.
I'm all for efficient pathways to identify patients at risk of significant liver disease, whether that's NASH or whether it's alcohol-related liver disease or even viral hepatitis. And I've said it before and I'll say it again, we have to make the pathways as straightforward and easy to use as possible, regardless of liver disease, and ideally using the same pathway and the same tests to allow primary care and other hospital specialties to identify those patients who need to see a hepatologist who would be suitable potentially for a specific therapy or other intervention that can be provided. And what I was saying before about the relationship between those tests and prognosis becomes more important, I think, because it's much easier to say to somebody that this patient's at risk of these events than it is to say their test's high, we need to see them, because it's more meaningful. You're saying something that matters to the clinician who's otherwise looking after the patient. You know, there's a risk that this patient will develop cirrhosis or will have liver cancer or will have a decompensation event at a meaningful rate, whether that's 1 in 50 a year or 1 in 20 or perhaps higher if it's an unrecognized patient with cirrhosis. So those types of mechanisms are helpful, I think, in prioritizing patients to get into hepatology care. The other thing that they're useful for on the other side is to make sure that where liver disease is relatively less important and where it isn't a primary focus for that, or shouldn't be a primary focus for that patient, that those those individuals are recognised at low risk and that testing stops, so they don't end up in the endless cycle of liver blood tests and screening and ultrasounds and stuff that they don't need. Because actually, if we can focus on those patients who are at greatest need, we'll get more positive feedback from those communities. We'll identify the people at risk. It'll be clear to the referrers that those people are at risk, and they'll be able to focus on those. And we need to provide them with better tools. And one of the other things that's happened during this year is the validation of various scores as it has been done, whether that's MRI-based scores or the agile FibroScan-based scores. The non-invasive test environment has matured. The pooled analyses from the Litmus Consortium have been published at the end of last year and through this year. So the quality and the impact of that data is improving all of the time. And the challenge now is to either to settle on scores and say, we think this is the best combination, this is what we should all use, because that'll help to standardize practice and make decision making for people easier. Or we say that we really don't know and we need lots more biomarker discovery. Now, I think I know where I stand on that. I suspect that we've got tools that for the uses that we need are going to be as good as they're going to get without lots and lots of costly intervention. But we need to see what's going to happen. I can see Jörn might be nodding at me or disagreeing. I'm not quite sure, but I'm sure that he's got a view on this.
I'm agreed, Ian. I think we have the tools we want. They're widely available and fairly cheap, and we can implement them. So when you were starting to talk, I was actually picturing like a traffic light system in my head, because I have these patients that come back every 6 months for an elevated GGT with no fibrosis, and they are not accepting that there is no liver disease risk for them, and they bother their primary care on that test to be resent to us, and then I show up and I go like, I told you last time that you shouldn't show up again. So these type of referrals, of course, are the ones that you would want to give the reassurance based on the data we're generating, based on NITs, no need for referral. And I think NICE is a little better and channeling that, but I would want to implement that for my practice in more stringency to be able to use and look at the ones that have a different traffic light signal and that are at risk of developing endpoints. And for that, for sure, there is more potential in biomarker development. And, we're doing a lot of scientific work around that, but I think we have the tools we need now to risk stratify, and we can move forward based on that. I'm aligned with you on this.
Yeah, I think that makes three of us, actually. Not that there isn't room for improvement or need for improvement, but these are probably not the things that need the most improvement the fastest, number one. And number two is one of the things that's happened this week, not surprisingly, with the publication of the MAESTRO-NASH results, is that stock prices have gone up, and not just for Madrigal, but for other companies with innovative products, Akero, Altimmune, just to name two. Some of that's about predicted M&A activity, but what that speaks to is the idea, I think I've been saying this all along, is that, and I'm not the only one, that one of the benefits of a positive trial is that money would flow in, and that even if money that comes in through pharma is not a completely unbiased educational tool, it is an educational tool in a place where we've got precious little education going out to lots of groups that need it. So I'm wondering where you believe, or where, Ian, in your practice and Jörn as well, if more money comes into the field through improved stock prices and investments, and big pharma deciding that it's now de-risked enough that they want to come into the game, how will that affect anything that you do today in a way that's tangible over, say, the next 2 to 3 years?
Well, the two biggest things, I think, would be disease awareness, because as soon as there's a marketed drug or interest from big pharma, there'll be education. I say that loosely, I mean advertising really, but education to hepatology, to related specialties, and probably also to primary care to some extent. So driving disease awareness, diagnosis, and patients coming through for treatment, probably not in the next year, but depending on what happens commercially and from a regulatory perspective, probably slightly later than that, but I'm sure that we'll see that. The other thing that I sort of hope is that, having had success in one form of steatohepatitis, we might see increased interest in alcohol-related liver disease to parallel that's going on in NASH. And I know that this podcast is focused on non-alcoholic steatohepatitis, but I was on the ward recently, and it's fair to say that the ward is not full of people who've got decompensated non-alcohol-related liver disease. It is by far and away alcohol-related liver disease that is still dominating our inpatient practice, and in many ways, that's where we have the greatest need for intervention to try and diagnose those patients earlier, which is why I said a shared pathway for patients with disease being identified, but also treatments to try and prevent the devastating outcomes that we see in those patients, many of whom are often young with families, and that I would really hope that we could or might see increased investment in that area too.
That's interesting. And I'm not sure I know how that dynamic works, because I think investment tends to follow proven patterns. It's always easier to get. So, for example, one of the questions we talked about earlier in the week was, if you had other THR betas in development right now, it would be easy to get investment on that. Easier than to get investments on modes of action that are unknown, because fundamentally what Madrigal just did was de-risk the mode of action. So you then have to take that over a disease, and you have to find a pathway for alcohol per se that's sufficiently de-risked that people want to spend money on it. And I think, given that we still don't have a successful cirrhosis trial, that may be a while coming. I hope it will evolve the way you just described, because that's clearly where the need is. But there may be a couple of steps left on that path, I would guess.
Yeah, I'm sure you're right.
On the other hand, somewhere in the middle, to the degree that we can do a better job of identifying and treating patients whose problems are both, if you will, the famous acronym BAFFLed, which I guess is going to go away as soon as we solve the rest of the nomenclature question. I would think for baffled patients, we might, if we solve the nomenclature question, or whatever, the solve is probably the wrong verb. I think resolve is probably the right word. There will be some resolution. It will not be a solution. It will be a resolution. Whatever resolution comes from that, my guess is baffled might go away, but those patients might be easier to target and identify now, one would hope.
So, and I agree with Ian that alcoholic also in my region is a big thing. The second aspect these alcoholic patients have is, of course, the addiction, which is not to the same extent happening in the non-alcoholic fatty liver disease. However, I do see a subset of alcoholic patients that are really surprised by the time they hit cirrhosis. They stop drinking and regress, and they're not as much, I think their risk of falling back to behavior, which we're seeing with NAFLD and, nutrition, lifestyle choices, is maybe a little less obvious. But then again, alcohol is the stronger toxin. It leads to more severe disease earlier. It's clearly a different class of patients.
Agreed. Conversely, one can live without alcohol. One cannot live without food, which means that every day there's a automatic temptation, at least twice a day, to be tugged back to the bad eating habits. Whereas if you can figure out your behavioral triggers, you might be able, and you're motivated, you might be able to stay out of alcohol. I struggle with sugar every day of my life, and I could give up alcohol if I had to, but I don't know that I could successfully give up sugar, given that I eat food 2-3 times a day, and foods tend to have sugar in it. So Ian, on top of all that, what are you working on in Leeds this year that you'd like to share with our listeners?
Well, the focus for 2020, or one of the focuses for 2023, is that our funding agency is going to run a specific call for studies in liver disease in 2024. And in preparation for that, they have launched 15 liver disease partnerships, and we're hosting 2 of those in Leeds. So we're going to spend a lot of next year doing preparatory work for funding applications in 2024. And the call from the agency is really around disease prevention and reaching groups that have previously had very little engagement in research, and that is specific communities, not around the big teaching hospitals, but more in the districts, and particularly around coastal areas which are deprived and have high rates of obesity, diabetes, and alcohol use. So we're going to work on engaging those populations, defining questions that those patients want answering from a research perspective, and doing a lot of work with other stakeholders across the whole of the spectrum, from primary care, from mental health and addiction services, into secondary care, liver disease, diabetes, obesity, and other related specialties. So it's going to be a busy year of workshops and talking to patients and stakeholders and bringing together all of the right people so that we can write compelling bids for funding to do studies that will impact patients down the line.
The one question I have, and something that's set up a little different everywhere, is the type of services you're offering. You mentioned, we have to adapt and change this, and I think we're focusing a lot of end-stage liver disease, so we have a separate cirrhosis service. That's like a mixed bag of etiologies in there. These patients that come decompensated or recompensated after an episode of decompensation are, of course, something where we might have to, the cirrhosis then takes off and defines the prognosis of the patient, but we still have to treat the underlying disease. And sometimes I think that's a little arbitrary, and to separate these from other liver diseases. And, moving forward and moving away from the definition of cirrhosis using histology, using NITs to define patients, I was wondering, or I thought about, setting up NIT clinics like a FibroScan clinic or something, even in tertiary care, because that's the way my system runs. I get them referred for suspected liver disease and go see a hepatologist, and not so much on cutoffs or NITs. So maybe you can share with us one more time, in your NICE setting, how you look at that, in terms of which end-stage patients do you want to see, how do you see them, how do you keep open your channels, and where do the NITs play a role? And I know, that's a lot of work you've been doing there in Leeds to set this up nicely. And I think it'll be nice for you to revisit that quickly for us again.
Yeah, thanks, Jörn. It's continuing iterative development process, those services. So we have direct access FibroScan from primary care to facilitate referral, and we see all of the patients, or at least attempt to see all of the patients who've got elevated liver stiffness, so over 10 at the moment. And those feed into initially a sort of triage clinic, and then they go into either disease-specific clinics if they haven't got cirrhosis, and I'll talk a bit about the end of cirrhosis in a moment. And those patients who've got cirrhosis either go into a clinic which is delivered by our expert specialist nurses for compensated cirrhosis, so making sure that they have their appropriate disease surveillance, or into a clinic for patients with early decompensation, which actually is extremely valuable, that clinic, because we have the appropriate support for that, both from dietetics and from transplant team where that's appropriate. The way that the field is moving away from, can we forget cirrhosis? Donna talks about moving away from biopsies, but moving away from cirrhosis would be a total shift in mindset. And the Vino consensus has really started to talk about that in the compensated advanced chronic liver disease way. The way that you manage a patient is really dependent on their risks of complications. We're not yet at a stage where we're formally assessing that risk, and we're still essentially labeling patients of having cirrhosis when we make a clinical judgment that that's present, and then they go into HCC surveillance and into the nurse-led services. I think to make it more rational and probably more evidence-based, as the sort of work that's being done by the Bovino investigators matures and we think about using primary prevention according to risk of decompensation or risk of clinically significant portal hypertension, then we'll be able to do a more formal risk assessment to decide what the appropriate follow-up is for patients, whether that's annual FibroScan, which we do for those patients who don't meet the Bovino thresholds for screening endoscopy, because we're still at the moment doing those. But if we do a formal risk assessment, then we could have a clearer pathway about how to manage those patients through those services. And in many ways, that would be the end of calling saying to a patient, you've got cirrhosis. We'd be saying that you've got significant liver disease and you're at risk of developing complications, and we'll address those by doing the following things. And that's a much more sort of cardiology risk-based approach rather than the traditional hepatology cirrhosis ordinal binary yes-no outcome. You've not got cirrhosis, so you're not at risk of these things. You have got cirrhosis, so you are, and that's obviously not the way that real life works. And we have to adapt the way that we think to try and incorporate what we're learning through the NITs and through the use of primary preventative treatments for patients who've got cirrhosis. Look, you see, I did it at the end. You see, there you go. The last word I said was cirrhosis, having said that we don't need to worry about that anymore. And it's so ingrained in our thinking and the way that we've been trained, it's going to be really hard to adapt away from.
Well, there's going to be another hepatologist following us, a new generation, and they might, talk about NITs and the target zones of NITs for a patient. And I think it's a great time to be here and working with, colleagues like you on this concept that we're moving away from the histological definition and more risk stratifying our patients. I like the cardiology concept, which, cardiology being one of the most dominant causes of death in our society is always going to be a little up ahead. We can learn a lot from them. So transforming that to liver disease is speaking about risk categories, risk corridors, and NIT target zones or something will be, I think, come to truth in hepatology in the future.
So that's really interesting. And I came at Ian's comment from a completely different direction, which is after a year, decades, but particularly a year in which we've all heard way too much, I think, about stigmatization and what words cause what different kinds of stigma. My favorite moment at AASLD possibly being when the Indian representative on the nomenclature panel said, well, in India, non-alcoholic is a good thing, right? So stigma takes different forms. But here's what we all know, although no one says this, that I see a lot. The word that's got the most stigma around it is cirrhosis. So, in fact, one of the things that happens, Ian, when you go down the path that you just described, is not only do we make this more rational medically, but we suck the biggest source of stigma out of the equation, right? Because whatever you did to get to cirrhosis, it had to be bad, and it probably involved too much drinking or too much something, right? But if you start to classify it in terms of the risks that you're trying to avoid, you can make the patient feel a lot more whole, and you can rationalize the discussion. At least that was my snap reaction to what you were saying. I don't know if you've had any experience doing that yet, but that feels to me like how it would roll out.
No, well, I've illustrated how ingrained the cirrhosis term is in the way that we think about patients. But I think you're absolutely right. And, and in common language, cirrhosis equals alcohol. And undoubtedly, that is a cause of stigma. And, if there are ways that we can address that do so.
Yeah, and frankly, before that, it was hepatitis, right? Which hepatitis leading to cirrhosis, but cirrhosis stemming from hepatitis has really bad stigma around it also. If we can resolve a lot of hepatitis and look at cirrhosis differently, we may have made some real progress on the stigma front without even worrying about this whole issue of alcohol, which I kind of think is secondary, at least personally.
And without any nomenclature changes.
Not sure you're going to get that wish, but dare to dream, my friend. So, Ian, as we close, one thought about 2023. What are you looking forward to this year? A, in your own work, and then B, we'll talk about the larger community.
What we're doing in Leeds, there's quite a lot to come in the next 12 months, both in terms of risks of outcomes in people who've got advanced chronic liver disease, not cirrhosis, and in terms of the impact of primary preventative therapies. So we've got some really interesting work that's currently under review, and I hope that we can come back and talk about that on another day, because I think it informs that risk-based treatment approach. And for 2023, the first thing I'm looking forward to is seeing the full manuscript of the resmetirom data, because it'll guide quite a lot of some work that we've got planned but need some more data for before it comes to reality.
That's a good and a realistic and unambitious starting point, since most people start talking immediately about drug approvals. So my hat is off to you for knowing when to walk instead of run, or to figure out where the next step is instead of how to leap across the lake in a single jump. So Ian, thanks as always for a fantastic discussion. When you join us, they always are. Let's you and me get a date that you think is appropriate in 2023 to share some of the Leeds data you just described. I think that'll be wonderful. And with this, to our listeners, we wrap up our end of year 2022 interview series. When we come back to you, it will be January, and we will be at NASH. Some of us will be at NASH. Some of us will be covering NASH. Ian, Jörn, thank you very much. With this, we can wrap up.
We hope you have enjoyed this discussion. Please join us next week, or should I say next year, for our coverage of the 2023 NASH Conference here on the Surfing the NASH Tsunami podcast.